everybody for joining us today. We've got a big day with Dr. Goyal here, who's going to actually talk about her experiences with Neurone. And that has been a topic that it's been coming up pretty much in every series that we've had. So I welcome Dr. Goyal and Michelle. Do you want to say anything, because it's a great pleasure that you're able to join us here at the Everything ALS event, and we have over 250 people joining us today. So I'm thrilled to have you.
As some of you may know, Dr. Goyal is one of the principal investigators for Brainstorm's trial of a mesenchymal stem cell called Neurone. And Dr. Goyal did some of her graduate work and at Mass General. She studied under Merritt, who was with us before. And so she is very much of that kind. And I have to share a story with everybody, Dr. Goyal. I hope I don't embarrass you. A lot of us talk about how much they love their neurologist and what matters to them. And everybody that I have heard from that treats with her has raved not only about what an amazing clinician she is, what an amazing researcher she is, but she has the compassion as if it was somebody that was her own family member. And I know that that's been a big issue for everybody in the ALS community. And so, Dr. Goyal, we love your credentials. We love everything you bring to the table, but I can tell you from speaking on behalf of all the patients here, we are especially grateful to you for the compassion and the humanity you bring to this insidious disease, because you make a big difference in the lives of the patients you're treating. And so that's why we're especially honored that you're the person that gets to talk to us tonight about this clinical trial that has the whole ALS community abuzz. And so thank you for joining us tonight. We're very, very grateful. And we'd love to turn it over to you so you can share all the great news with us.
Well, thank you, Michelle and Indu, for that really humbling introduction. I do want to thank Everything ALS for bringing me here today. It's truly an honor to speak to you guys. A little bit about me, as Michelle and Indu were saying, is that I started my career in ALS at Mass General, and very early on in my career, I thought ALS is probably one of the cruelest diseases that I have ever seen, comparing it to all of the diseases that I had encountered as a medical student in different subspecialties. And I thought, with all these advancements that have been made in science, how is it that we don't have an effective therapy to slow down disease progression in ALS? And I thought, I'm not going to stand for it. I will do whatever it takes. And I really made it my passion, my mission to help all my patients. And I consider anyone in ALS my patient across the world. And I made it my mission to find better therapies. And I really believe with Neurone, we are doing something bigger and different than any of the drug trials that have been done before. And so I'm so honored today to be here and tell you about the story of Neurone. So in the next 45 minutes, I just wanted to very quickly give you a brief overview of what stem cell therapy is and discuss some of the major stem cell trials that have been formally conducted in the US and what the technical differences were between Brainstorm as well as some of these other trials, and then really focus on the story of Neurone's development in ALS and what it has brought to the table. So I don't have to tell this audience, but as many of you guys know, the mechanism of ALS is still largely unknown. And there's a lot of hypotheses. As you can see, this complex diagram is really brought to the table because it illustrates the complexity of the potentially different causes of ALS, from inflammation to toxic factors to glutamate toxicity, potential gene mutations causing ALS, oxidative stress. And so there has been more and more attention drawn to maybe it's not one of these pathways that we need to direct drug development to, but maybe it's several pathways where we're finally going to develop a successful therapy if we target multiple pathways. And that's where I think stem cell therapies come in. How can they really help? Well, this is just an illustration of the intact nervous system in healthy individuals. And as many of you know, motor neurons lay in our spinal cord and in the brain, and they're really surrounded in the CSF by supporting glial cells that create a healthier environment. There's growth factors involved to promote motor neuron survival. And this really all involves a complex interplay to keep this motor neuron robust and surviving so that it can generate a signal down the nerve axon to the muscle and cause a muscle contraction or the muscle to move. However, in ALS, what has been postulated is that there is a compromise at the blood-brain barrier. So leaking through the CSF, there's potential toxic agents that kill off these supporting cells and decrease the availability of growth factors to keep that environment healthy. A lot of analogies sometimes people use is that if you have a beautiful house in a bad neighborhood, surrounded with insects and animals, they can eventually infiltrate and affect the house and kill off the house. And so similarly, the surrounding environment is thought to be very important in a motor neuron's viability. And so in ALS, with this disrupted, eventually the motor neuron dies. The signal going down the axon gets weakened, and so the axon withdraws from the muscle, and in turn, patients develop muscle atrophy and muscle weakness. However, stem cell therapy may be a targeted therapy in ALS that can help create this healthy environment. So a lot of patients ask me, well, what's the difference from one stem cell therapy to another? And why not go to Mexico or China where I can get these stem cells and not be a part of a clinical trial? It's really important to ask yourself what the stem cell is actually treated with. The way I visualize this is that the stem cell is just a vehicle driving through the CSF, and the stem cell in this case has been treated with Neurone. And so it's able, driving through the CSF, it's able to deliver and release the treated agents of Neurone, like growth factors, reducing the inflammation, and essentially creating a healthier environment, promoting motor neuron survival. I know I'm simplifying this illustration, but that's really sort of the conceptual basis of why stem cell therapy may help. And so over the years, there's actually been three major, I know there's been several trials that are either ongoing or happening in ALS, but they're in the US here. There's been three major trials, one by Neurostem, that phase 1 and phase 2 completed in 2015. N means the number of patients that were enrolled, so 15 patients each. Cedars-Sinai also did a similar phase 1/2A trial with 18 patients that was completed approximately last year. And Brainstorm has been the most advanced because it has, one, done the largest number of patients, but also has advanced in different phases. So a little bit about what phases mean is that phase 1 generally is looking at safety. Is this drug safe? In this case, a stem cell therapy, is it safe to perform in an ALS patient? And generally it's tested in a small number of patients because they don't want to harm a large number of patients if, in case there is any safety issues. If the safety is passed, trials are able to move on to a phase 2 study where safety again is explored. Safety is really important because we've learned from other trials, drugs can harm ALS patients if they aren't appropriately performed. And so this phase 2 study was done to evaluate safety, but also explore efficacy. And then Brainstorm is the only one of these three stem cell trials that has moved on to a phase 3 study. Not to say that these trials couldn't move on but it takes a lot of data, a lot of funding to move on to phase 3 studies. And I will tell you, we had done an analysis from 2007 up till currently. There have been over 85 trials done, well over 85 trials done in ALS, and very few trials make it to phase 3 because most trials are able to prove safety, such as in phase 2, but then aren't able to totally prove efficacy in phase 2, and so they end. So also an encouraging fact for Brainstorm to be able to move to phase 3. And then I wanted to just quickly review for you some technical differences between the first two trials versus Brainstorm. So NeuralStem and Cedars-Sinai use stem cells from a fetus. So they're human neural stem cells derived from a spinal cord of a fetus. And what that actually means is if you're getting stem cells from another person, it's considered an organ transplant, just like if you were to get a heart transplant or a kidney transplant. And so patients had to be placed on immunosuppression medications. We all know immunosuppressive medications can cause nausea, vomiting, and in an ALS patient, that can be a pretty strong side effect when you're already dealing with the disease itself. And then number two, another important technical factor were these patients required a spine surgery. So these stem cells were injected directly into the spinal cord, and to get to the spinal cord, they had to open up the spine, do a surgery, and then they took a needle and directly injected into the spinal cord. So pretty invasive, and anytime something invasive happens, there are more serious complications that can occur. What was nice about the Brainstorm study and different from the other two is, number one, they have used the patient's own stem cells derived from the patient's own bone marrow. So again, not using another patient's stem cells means that no immunosuppression was required. A very nice factor where we didn't have to worry about adding on other medications and potentially causing nausea, vomiting, or side effects. And then another second very important technical factor, as a physician taking care of my patients, I always want to make sure we're not doing harm to these patients when we're testing a drug. And I was relieved to know that no spine surgery was required. The stem cells were injected directly into the spinal fluid with a small needle, just like a spinal tap is being performed. So no surgery to inject the stem cells. Important technical factors as we all start moving forward and thinking about what the future entails for Neurone. And then I'm going to go over in the next few slides what these different phases meant for Neurone. So the rest of this talk, I really want to focus on the journey of Neurone. And what's so interesting about Neurone is that they have been invested and very interested in drug development in ALS for well over 10 years now. There's been some very important scientific data that started with Neurone in preclinical lab work since 2007. And then the first phase 1, phase 2 studies were started in 2010. They were done in Israel. You can see here on the top chart the number of patients that were enrolled in each part of the different phases and where they were published. The phase 1, 2, and 2A studies were all open label, done in Israel. So open label means that all patients in the study received drug. And the 2A component of the study, they were testing higher doses of the drug in a single injection. And what was nice to see is that these studies were safe in order to move on to the phase 2 study that was all done in the US, 48 patients, started in 2014. And I'll show you, we'll talk a lot about the phase 2 study and the results. And I think it's going to be very helpful for all of us as the ALS community to understand these results, which will help us interpret the phase 3 results when they're released, anticipated at the end of the year. And I'll talk to you at the end of this talk about exact timeline of the study, but the phase 3 study was started in 2019. And so Neurone, I'll direct your attention to the right of the slide here, where there's been several factors that have been thought to have a mechanism of action in ALS with Neurone. It has been shown that CSF caspase-3 is reduced with the administration of Neurone. Now, caspase-3 is an activator of neuronal apoptosis, which means cell death. And if it can reduce caspase-3, it can have effects of neuroprotection. There's also a lot of data, and which I'll show you, and Brainstorm has kindly shared these slides with me, is that the CSF growth factors has increased when patients are treated with Neurone. Additionally, there are some inflammatory markers such as these that have been reduced when patients are treated with Neurone, and I'll show you this data. But how does the actual technology work? What happens exactly with the patient? Well, I think this is a nice illustration showing that the patient gets a bone marrow aspiration from this region where their bone marrow is harvested. This happened at our center here at UC Irvine. And then their bone marrow is sent to a manufacturing lab. So in the phase 3 study, there were 2 labs set up, one here in LA at City of Hope and another lab set up in Boston, where the bone marrow was sent and mesenchymal cells were taken and isolated from the bone marrow population. The mesenchymal stem cells were then expanded in the lab, differentiated, treated with Neurone. And approximately a month later, the stem cells were sent back to us. And I'm speaking from our institution at UC Irvine, so the patients that were enrolled at our site would come back to our site a month later, where they would get the Neurone-treated mesenchymal cells injected back into their spinal fluid. And we'll talk more about study design, but I just wanted to show you briefly how this technology works. And that's what's really important, and that's what differentiates Neurone's, Brainstorm's Neurone from other stem cell therapies, is what the mesenchymal cells have been treated with. There are several beneficial effects of mesenchymal cells that are primarily mediated by secretion. So this figure just shows that it's secreting growth factors, it's promoting growth factors to promote neurogenesis or neuronal growth. It can help regulate T cells to reduce inflammation and increase the formation of cerebral blood vessels to help in turn create a healthier environment for motor neuron survival. And so what did we learn from the early phases of Neurone? Well, we actually learned some interesting data, which Brainstorm shared with me to share with you guys. So remember, this is the phase 1/2 2A study where it was approximately 26, 28 patients. And these were all open label patients, so meaning all patients got Neurone. And what they found is neurotrophic factors. These are different neurotrophic factors. And the light blue are the Neurone-treated mesenchymal cells. And when the mesenchymal stem cells were treated with Neurone, the light blue, you can see that the growth factors were increased in several different types of neurotrophic growth factors. Again, growth factors are agents that really help promote survival of motor neurons, creating that healthier environment. And then, as many of you guys have heard already and know, is that there's been a lot of interest in T regulatory cells. briefly, in normal individuals, healthy individuals, T regulatory cells are good cells. We want high levels of these because they help reduce unnecessary inflammation that can occur after an immune response in the body. And so previous literature has suggested that T regulatory cells are actually decreased in ALS patients, and potentially why they have higher levels of inflammation. And what you could see, and this is from, on the left is the phase 1/2 study, and on the right is the phase 2A study. But in both studies, you can see that within hours in the blood, after Neurone injection, T regulatory cells were increased. This is at 4 hours. And then it really persisted up till about a month. In both studies, you can see these effects. Pretty compelling and interesting data. If inflammation is really playing a role in ALS, this could be a very helpful finding. So these findings, the biomarker findings, as well as the findings of safety, remember phase 1 is primarily conducted to show that injecting Neurone into the spinal fluid was safe. There were no serious side effects. All of this generated a lot of enthusiasm and sort of the path forward in moving on to a phase 2 trial. So the phase 2 trial was done in the US, and there were initially 3 investigational sites, Mass General and UMass, both in Massachusetts, and the Mayo Clinic in Minnesota. And this was 1 injection of Neurone. They enrolled 48 patients. And what was nice about this study, I like the study design because they randomized patients in a 3-to-1 ratio, which means that 36 patients got treatment and 12 patients got placebo. And so here is the timeline of the study design. And I'm just going to walk you through it. I hope you can see my arrow. But the screening process actually was approximately 3 months. And this was because they were just evaluating ALS patients to measure without any treatment, just seeing how an ALS patient was doing and measuring their rate of disease progression to establish a slope. Once the slope of the rate of disease progression, how fast they were progressing, was established, 3 months later, approximately, they received the bone marrow aspiration, and then where the bone marrow was sent to the manufacturing lab, mesenchymal cells were treated with Neurone, sent back, and a month later, they received an intrathecal injection at visit 5. 2 weeks later, they had a spinal tap to get CSF, to get spinal fluid, just for an analysis of what's happening after Neurone injection. And I'll show you this data. And then the end of the study was 24 weeks later. So again, another schematic of trial design. You can see here 48 patients were enrolled. They were randomized 3-to-1, meaning 36 got treated, 12 were on placebo. And spinal fluid was collected immediately before they received the Neurone injection. And then 2 weeks later, they came back to clinic where another spinal tap was performed, so their CSF or their spinal fluid could be sent for analysis. There were several follow-up visits in between, and then the final visit was conducted at week 24. So what the phase 2 study found was that it did meet their primary endpoint. The primary endpoint of the study was to demonstrate that injecting Neurone into the spinal fluid in 48 patients or 36 patients versus 12 was safe and tolerable. The study proved that there were no deaths, there were no serious treatment-related side effects, and none of the patients even dropped out from treatment-related serious side effects. The most common side effects were actually mild to moderate in severity, and mostly procedure related. And then there were some very interesting secondary endpoints that were captured. One being the ALS-FRS slope. And many of you also know about the vital capacity, and this was also examined. But what I'm going to talk about is the ALS functional rating scale. So as many of you know, the ALS functional rating scale is a validated and an accepted measure of how ALS is progressing. It's a 48-point scale, and it was actually the basis for how Radicava got approved in 2017 when they looked at the mean score change at 24 weeks. We've also learned from a PROACT database that the ALS-FRS decline is about 1 point per month in the average ALS patient. And if you can change the rate of disease progression, or that slope, by about 20 to 25%, that has been accepted as a clinically meaningful measure and a perfect acceptable measure to say that the therapy is effective. So in the phase 2 study, these are confusing graphs, and I'm going to try my best to simplify this. But I'm going to draw your attention to figure A on the left. And what you'll see is in blue are the patients that were treated with Neurone, and red are the patients that were on placebo. And these are a diagram of how the patients did based on their ALS-FRS rate of progression in all 46 patients. And basically, they're looking at the change of the slope post-treatment in comparison to that 3-month run-in period, or the pre-treatment slope. And what you can see here is really there was no significant difference post-treatment to pre-treatment in all the patients treated versus placebo. However, a very interesting pre-specified data point that they found out was that the patients that happened to be rapid progressors, these are the patients that dropped in their ALS-FRS score by over 2 points. They were deemed rapid progressors. There were 21 patients in the study that were rapid progressors. And a very important finding that they noticed is that after a single injection of Neurone, they were able to slow down the rate of disease progression. So blue are the treated patients, red are the placebo patients, meaning that their ALS-FRS slope slowed down post-treatment in comparison to the pre-treatment slope. And this was noted statistically significant at 2 to 4 weeks, so especially at early time points. Just to sort of understand this concept further, I'm going to walk you through what is meant by the change in slope. So the top figure is an example of one of the patients in the placebo group. And what you can see on the top figure on the left side is that in the pre-treatment group, in the placebo patient, pre-treatment, the rate of decline, or the slope of change in their ALS-FRS score, was negative 0.59. They got placebo, and you can see that their slope continued to progress at negative 0.86. So there was no significant improvement. In fact, it actually, continued to decline. On the bottom graph, you see an example of a patient in the phase 2 study that was treated with Neurone. And what you can see here, a very interesting and exciting finding, is that before the treatment, the patient is progressing at negative 2.1, a very steep slope. You see the solid blue line. And then after the single injection of Neurone, his slope had slowed down in progression. You can see the solid line is what his actual slope was. If he didn't get treated, this was the trajectory, and you can see that the slope improved by negative 0.2. So if you take that slope measurement of negative 0.2 minus the pre-treatment slope change of negative 2.1, you can see that the slope actually improved by 1.90. I hope that makes sense to everyone. That's a really important point as we're moving forward and going to be anticipating the phase 3 results. So they deemed that someone who would respond to Neurone was anyone that had a slope improvement of greater than 1.5. Again, that their post-treatment slope of progression slowed down in comparison to the pre-treatment. And then another point I'll make is this is what's called the responder analysis, and I'll draw your attention to figure D on the right side, where you can just look at the rapid progressors. And when they analyzed the subgroup of the patients that were progressing rapidly, a higher proportion of these patients were responders, so responded at greater than 1.5 points per month in the patients that were treated with Neurone at all time points from 2 weeks, 4 weeks through 24 weeks, and were significant at 4 weeks and 12 weeks. You may notice that definitely by 12 to 16 weeks, you can start seeing the response taper off, which was the basis of the design of the next phase 3 study, which is why they did multiple injections. And I'll tell you a little bit more about that. So I also wanted to share some very nice data that Brainstorm shared with me. And this is the biomarker data. So remember how I said that patients had their spinal fluid analyzed before treatment and then 2 weeks after treatment. So the dark blue is before treatment. The green is 2 weeks after treatment. And you can see in 26 of the Neurone treated patients, the growth factors, many different kinds of growth factors, were significantly improved. However, in the placebo group, there was no change in these growth factors. I think very compelling evidence. What was also very interesting is that inflammation is thought to be a culprit and a problem in ALS. And MCP is an inflammatory marker. So high initially before the patient received treatment, but when the patient received Neurone, there was a significant reduction in this inflammation marker in the treated group, but there was no significant change of inflammation in the placebo group. And in fact, the reduction of inflammation of these inflammatory markers was not minuscule. It was by up to 40%. Pretty compelling evidence. And again, another complex diagram, but I'm going to walk you through it. And I'd like to draw your attention to the top right figure, where you can see MCP is in the bottom. And MCP, remember, is an inflammatory marker, so high levels are bad. The red dots are individual placebo patients, and the blue dots are individual patients that were treated with Neurone. You can see the placebo patients had high levels of MCP or inflammation, yet the treated patients had a reduction in MCP, which correlated inversely with high levels of growth factors that's on the vertical axis. And what's also interesting, I'm going to draw your attention directly below, where you can see the blue dots are, again, all treated patients with Neurone. They had the patients that had the lowest inflammation and the highest level of growth factors also had the best functional rate of progression decline, slowing of progression. So that improvement in the ALS-FRS slope was the most optimal in these patients, but you didn't see the same effect in the placebo patients. Pretty compelling evidence. And then finally, I'll just direct your attention to caspase-3. Remember how I said that caspase-3 is a protease that is involved in the activation of neuronal apoptosis, or in other words, neuronal cell death. And so high levels are bad, lower levels would potentially be good for survival. And you can see on the left that patients that were treated with Neurone, visit 5 pre-treatment, they had high levels of caspase, but after treatment, within 2 weeks, these caspase levels were reduced. And then in the placebo group, you didn't see a statistical significantly different in these caspase levels. So just to summarize the phase 2 results, the study met its primary endpoint. It was safe and well tolerated to inject patients with Neurone. There's some very compelling biomarker data that we learned in their spinal fluid. There's an increased expression of growth factors, a decrease in inflammatory markers, which all support the hypothesis that Neurone increases neuroprotection and decreases neuroinflammation. And most importantly, they found that in the rapid progressors that were enrolled in this study, there was a significant efficacy seen in the slowing of the ALS-FRS-R slope, or the rate of decline, when you compare post-treatment from pre-treatment. And so these findings were really compelling evidence to move on to a very large phase 3 study, where there were 2 differences from the phase 2 study, this time only enrolling the rapid progressors, since that's where they saw the efficacy, and also doing repeated doses of Neurone. And so 3 injections were performed. And this time there were 6 sites involved. So the 3 former sites, MGH, UMass, and Mayo Clinic. And then this time there were 3 sites in California, which is where we came into play here at UC Irvine. And I'm proud to say that we enrolled the most patients. We recognized, as I mentioned, my passion and my mission to find better therapies for all ALS patients. And so we really wanted to do this trial as fast as our institution could handle. And we made that a mission in completing this trial. And so here is what the phase 3 study design looked like. Similarly, again, there was approximately a 3-month screening period where, again, they were evaluating the ALS patient without any treatment, but just seeing what their rate of progression would be over a 3-month period. And if they were a rapid progressor, they had a significant decline in their ALS functional rating score, a steep slope, they would be enrolled in the study. So they would be randomized. And this time the randomization was 1-to-1. So 50% got placebo and 50% were treated. The bone marrow aspiration was done. And then a month later, the green are the time points where the patients were treated with Neurone. So at time point 1, 2 months later, at 8 weeks and 16 weeks, for a total of 3 injections. And the end of the study was conducted at 28 weeks. So another summary of the schematic of the trial design, where approximately 200 patients were enrolled. They were randomized in a 1-to-1 distribution. The bone marrow aspiration happened, and then 3 treatment periods, each 2 months apart. This time, spinal fluid was not only collected at the 3 injection periods, but even in between visits. And so there were a total of 7 spinal taps done in the study, all to collect spinal fluid and really analyze what is happening when you treat the patient with Neurone. And I'm just going to take a second and pause here, because I really want to do a large shout out and thank all the patients that were in this study, placebo or treated. They were selfless. If you think one spinal tap is hard, imagine getting 7 spinal taps. And at least of my patients, not a single patient complained. They were my true heroes in doing the study because they knew that this would be amazing science. And I will tell you that I think this is probably going to be the largest spinal fluid data collection we've ever seen in ALS. So regardless of what happens with the results of the study, if it's positive or negative, Brainstorm is doing tremendous work. And I give kudos to the scientists at Brainstorm for thinking about all the different biomarkers that are going to collect and analyze and learn from this study. The ALS-FRS was also collected over 13 times, and the final visit was conducted at 28 weeks. So this time in a phase 3 study, they're really just trying to figure out, does this drug work? And the primary endpoint is going to be evaluating if the ALS-FRS slope of decline that we've all talked about now has improved or slowed down in progression. They are going to look at several secondary endpoints, from safety to vital capacity to several biomarkers, both in the blood and the spinal fluid, genetics, and the trial has been fully enrolled. So there are some key differences between phase 3 and phase 2. Like I mentioned, phase 3 did 3 injections rather than a single injection. And this was because, as many of you may have seen in some of the graphs that I showed, that the response in phase 2 may have been tapering down. And the phase 2 data suggested that if we inject potentially every 8 weeks, we could get a more sustained or potentially better durable response. The phase 2 study also showed us the best results were in the rapid progressors. So you always want to design a study for success. We're all on the same team. I've gotten several questions about why they were so specific in enrolling patients with a specified inclusion criteria. And it's because at the end of the day, the scientists, the physicians, the patients, of course, the ALS community wants successful treatment in ALS. And they saw from the phase 2 study that the rapid progressors had the best efficacy. So why not design a study where we're selecting out that group to try to lead into that success? And then the last thing I'll mention is, remember how I showed you those slopes of change of the ALS-FRS. And in the phase 2 study, they were looking at an improvement of 1.5 points per month. What's nice is that they lowered the bar, and they found that in the rapid progressors, a change in that pre-treatment slope versus post-treatment slope of greater than 1.25 points per month in the ALS-FRS slope change would be clinically relevant and would be valid. So that is their target for the phase 3 study. So just to remind you, this is not results, it's just an illustration or an example of what we're looking for. I'll direct you to the bottom graph where you can see the slope again of a patient without treatment declining by -2 points. And then once Neurone is administered, the slope changes and improves and slows down by only -0.21. So this difference you can see in the chart here on the right is 1.89. And a responder, someone who responds to Neurone, would just require improvement of greater than 1.25. Of course, we're also going to be looking at several other biomarkers. And so in summary, here's the timeline. The study was started in 2017, around end of 2017. And the enrollment, so approximately 200 patients, completed the enrollment of the study. But remember, this is about an 11-month study. And so while the enrollment was completed in November of 2019, the last patient last visit, and we had one of these last patients, was done just last month. And what I'm proud to announce is that when COVID hit in March, Brainstorm immediately got on the phone with all the investigators at all the sites, and we had urgent conference calls. And many institutions were shutting down research, but we were all fortunately able to talk to our institutions about understanding the urgency of getting an answer for the ALS community. And we did not have to stop the study. And so there were no delays from COVID-19. And I'm fortunate that the scientists in Israel at Brainstorm were able to continue, and we were all able to continue. And I'm mostly thankful to the patients that really are the true heroes of the study, dedicating themselves selflessly to be involved in this trial. So right now, October, since this is the month where following the last patient's visit, all the sites are currently entering the data fast and furiously. And this has been going on through the trial, but they're checking and rechecking everything to make sure everything has been entered accurately and completely. And we're anticipating that database lock will happen at the end of October, which means then Brainstorm will get the data, and they, many companies, sometimes I've worked with so many drug trials in ALS, sometimes analyzing the data itself can take months. But Brainstorm has announced that they are trying to deliver top-line results by the end of November, early December. And big kudos to them, because this is going to be a lot of data to analyze. And so I also wanted to share with you a patient of mine that was enrolled in the study. This is public knowledge. Just so you all know, I don't know what he received, and he doesn't know what he received because he was still blinded. But ABC News wanted to interview him about his experience. And so it's about a 3-minute video, but I wanted you to hear from a patient what this trial, what Neurone meant to him. And so I'm going to play the video for you.
45-year-old Eric Schwartz has lived his life focused on his family and his job in fitness.
Can you make a muscle? Don't let me pull.
Now, physician visits and his fight with ALS or Lou Gehrig's disease fills his mind. His motor neurons are quickly dying off.
There was no treatment, let alone a cure. I mean, there's just nothing.
And within 2 to 5 years, they lose the ability to move, to speak, to swallow, and eventually breathe.
I remember going to appointments and hoping it was cancer.
Shortly after his diagnosis, Eric learned about the ALS Brainstorm clinical trial at UC Irvine. Dr. Namita Goyal is investigating a therapy engineered from a patient's own harvested cells.
These stem cells then secrete growth factors to promote motor cell regeneration, reduce inflammation, and the idea is that their motor cells can live longer.
Stem cells are taken from a patient, brought to a Brainstorm lab, where it's specially treated and injected back into the patient within a month. That'll happen 2 more times over the course of 28 weeks.
We've enrolled you in a clinical trial.
A month after his first injection, Eric noticed improvement in his hands.
I looked at my wife and I said, this is incredible.
UCI researchers, along with 5 other centers, want to enroll 200 ALS patients in this phase 3 trial.
It's empowering to have hope, both for the patient and the physician.
The details are on our website at abc7.com.
It's a long shot, but man, it has changed, honestly, how I get up in the morning.
And I thought that would be really important for you guys to hear from a patient himself. And then I'm just going to end with some messages that have really resonated with me from ALS patients in this trial. A very, clinical trials in general in ALS can be challenging because we know the condition is challenging. It's every day is hard. And so I told one of our patients, I'm sorry, this trial is so difficult for you. And I understand how difficult this is. 7 spinal taps is not easy. And the patient just calmly looked at me and smiled and said, we do difficult every day, but with this trial, we may just do the impossible. We may find a treatment for ALS. And some of these quotes really have resonated with me. And then I just had recently another ALS patient just a few weeks ago tell me, never, 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 never give up. A quote from Winston Churchill. So I'm going to end with a very special and humbling thank you from the bottom of my heart to the patients and their families who have been involved in any ALS trial, especially this one, but also all ALS patients across the world, because we are really fighting for you and we understand the urgency. This is some of my team members at UC Irvine, and I really want to thank them as well, because Vina, Jeanette, Veronica, Martin, they're all my coordinators that have worked day and night to make this trial happen. Our hematologist doing the bone marrow biopsy, the stem cell teams, and of course the brainstorm team. A big thank you to them, because I feel like from the CEO, Mr. Lebowitz, to the Chief Medical Officer, Ralph Kern, and Mary Kay, who has really advocated for patients all across the nation and world. The brainstorm team is a remarkable team that you can really feel their passion in trying to develop Neurone for every ALS patient out there. So with that, I'm going to thank you guys for your attention, and I'm happy to answer questions as I can.
That was wonderful. We do have a couple questions. I don't know if you want to keep your current screen up. You're more than welcome to. Otherwise, I want to introduce myself. My name is Sarah. I am part of the Everything ALS team, and I'm really honored to get to speak to you tonight. It'll be myself and James who will be asking a few questions that were in the chat.
Would you like me to stop sharing, or?
That's totally your choice. Whatever you want to do is 100% okay.
Maybe I'll keep it on in case anyone wants to see something or revisit any data points.
Absolutely. All right. So our first question, which kind of came up a lot, is we're both familial and sporadic patients in the phase 2 and phase 3 trials.
So I've been involved in the phase 3 study, and so I do know that familial patients or patients with a genetic mutation were included in the study. No one was excluded based on genetic mutations.
Okay. For kind of expanding on that, were the study also looking at, I know we talked a lot about how fast, like rapid progressors were in the phase 3, but did that also include bulbar, limb onset? Was there any exclusion on the initial starting point of symptoms?
No, the inclusion criteria was really, of course, there were several inclusion criteria points, but region of onset was not exclusionary or inclusionary data point. So bulbar onset was included, limb onset was included. It was really if they could perform a robust forced vital capacity of greater than 65%.
Okay.
Hi, Dr. Goyal. Next question was, were patients with FTD included in the studies as well?
We didn't exclude FTD patients if they had ALS. The primary inclusion for the phase 3 study was really based on if they had ALS, they needed to have symptoms for less than 2 years. And FTD, if it was FTD ALS, it was not exclusionary, as long as FTD, for patients out there who don't know, is frontotemporal dementia. And as long as their cognition was relatively intact, I mean, if they had severe dementia and couldn't follow commands, didn't really understand the study, couldn't sign the consent form. We, of course, cannot include any patient, not just someone with dementia, if they can't understand the study. But someone with mild cognitive issues or mild dementia was not specifically excluded.
In terms of the procedures to retrieve and return the stem cells, were there any difficulties with patients who might have a decreased respiratory drive? I know you said their forced vital capacity had to be high enough, but did you see any issues with going through that procedure and the respiratory system specifically?
So their forced vital capacity or slow vital capacity had to be greater than 65 upon entry. However, as many of you know, the forced vital capacity can decline over time. And you would anticipate, and if the placebo group is not getting treated, 50% of those patients are going to have that natural decline. So it's not like that would make them drop out of the study. We continued to do all of the measures as long as they were safe and well tolerated. And you'll be seeing that data when the phase 3 study is released. But just from personal experience, you can do a spinal tap in someone with a reduced forced vital capacity.
To go back into some of the exclusion questions, has there been or were there a maximal ALS FRS for exclusion in the previous trials?
So I know for the phase 3 study, it wasn't based on a maximum. It was just based on, do they have an appropriate ALS FRS rate of decline? And that was a pre-specified number that deemed them as a rapid progressor. So it wasn't like they had to have a high top number. They just had to have a rate of decline that was pre-specified as a rapid progressor.
In terms of the Treg cells that you discussed in your presentation, were there any factors that you know of that might decrease those Treg cells besides just ALS? And could that include something as like allergies, or what maybe causes the decrease?
Yeah, that's a great million-dollar question. And I think we do see this in other conditions, other diseases. There are other neuromuscular conditions that have muscle weakness where we're trying to learn and understand what the T regulatory function is. But overall, what we've seen in the literature is that T regulatory cells are good. And when they are low, they potentially are associated with abnormal inflammation. And maybe they aren't working in the immune system to clear out those inflammatory cells. And so a thought is if there's a way you can boost up these T regulatory cells, which potentially Neurone may do, can you clear out some of the inflammation that is seen in the spinal fluid?
While we're on the topic of Treg cells, were the Treg cell counts measured throughout the phase 2 and phase 3 studies?
So the data I showed you was from the phase 1, phase 2 studies. And I know they have been doing a lot of interesting biomarker data in the phase 3 studies, and there's been a lot of interest in Tregs. And we'll find out hopefully soon.
It's going to be a big day at the end of November, early December. We're all very excited. We're all very excited.
This is something that I think I've been excited about since 2017. That's for sure. I know a lot of patients are asking what those exact next steps are. And really when, let's say, and let's hope and pray that if these results are positive, I do know that Brainstorm is already trying to prepare an application to the FDA. They have to obviously wait for the results, so that'll happen end of November, early December. And as soon as they get the results, then what they have to do is prepare a very large application and submit it to the FDA. The FDA, and I'm speaking from my knowledge about the way other clinical trials work, but the FDA in general has about 60 days to review the application, meaning just say, okay, yes, we accept the application, or no, we're rejecting this application. So that process can take up to 60 days. I'm not saying it will take 60 days, but they are allowed 60 days to review it. And then from that time point where they click accept, hopefully, then they have up to another 6 months to actually review all the data and decide if they're going to approve a therapy or not. They know that ALS time is of the essence, and I know there's been several discussions, both from patient groups as well as from Brainstorm, alerting the FDA that this is about to happen and we're about to get results. And so there are certain tracks that can happen, and the FDA may prioritize this and try to do what they can to appropriately analyze the data and expedite what their answer back will be. So could this be as early as the spring of 2021 to the summer of 2021? I mean, I think all of that may be fair game. And I'm speaking vaguely. I don't work directly with the FDA. This has just been my experience from other clinical trials.
Thank you for that explanation. In terms of the phase 2, because we do have those results, were there any situations where progression was not just slowed, but actually you saw increases in the FRS scores?
Yeah, that's a really important question. And I want to take a minute to pause and say how this study was different than many of the clinical trials that I've done. I think that 3-month run-in period is a very important point that I hope all patients understand. Some patients think, oh, why are we monitoring a patient for 3 months without doing anything? But we all know in the ALS community, I mean, there's so much talk about ALS being a heterogeneous disease, meaning that ALS rates of progression differ from one patient to another. And so to loop patients or clump them all in one group as treated patients, you can sometimes miss the boat in a treatment effect. However, what's unique about this study is that they took each individual patient and looked at their pre-treatment slope and compared it to the post-treatment slope. And yes, in some patients, there was a quote improvement post-treatment. Now, which is, you know, sort of a very interesting concept. Like, was there truly an improvement, or was it just that there was such a significant slowing, or was there potentially a treatment effect? Do we think these treatment effects were permanent? I think we learned from the phase 2 study that even if there was an improvement, you saw the curves at different time points. At 2 weeks, 4 weeks, there were significant improvements in these slopes, but then the effects seemed to wear off. And that's from the phase 2 study. So that was one injection. So was it because there was a treatment effect of improvement and then it just wasn't sustained? Or, and not to be a pessimist, but sometimes there is a placebo effect that happens. But I'm not really a pessimist here, because in this case, you do see that the red bars were the placebo patients, and then none of those patients had those trends of improvement like the Neurone treated patients. And that's where placebo comes in to be a really important group, because you're performing the same procedure, the patient thinks they're undergoing the same treatment, and yet there's no treatment effect. And that's where the theory of a placebo effect of, oh, maybe I think I'm getting drug, counters it and provides even more robust data to suggest that Neurone was effective in the rapid progressors.
Kind of to go off that, in the case of the slow progressors, what are your thoughts as to why slowing of the rate of decline post-treatment in phase 2 was seen more in rapid progressors versus the slow progressors?
James, that is such an important question. I'm so glad you asked it. I wanted to make it a part of my talk, but then I thought people may just get lost in the data. But I actually think that is like such an important point, because all patients want to be included in a study, and we want that for all patients. We want to treat everyone if we can. So, you know, of course, there were a lot of angry patients of, well, why are you only including the rapid progressors? But if you think about the concept of treatment duration, so remember, this study is only 28 weeks. So what, approximately 6-7 months where you're evaluating the patient to see if there's a treatment effect. In the slow progressing patients, where the slope was changing by negative 0.5 points per month, you can see that to try to make an effect on a very short duration, you may not see that effect. However, in a rapid progressor where the slope is much steeper, like this, in a short amount of time, you can show a robust treatment effect. So I suspect it's not that Neurone doesn't work for a slow progressor, but it may take, because the slope is so slow, it may take a longer time to show a treatment effect. It may take 2 years instead of 6-7 months. And so I hope everyone's following that understanding, because a lot of us right now are facing the challenge, us meaning the ALS physicians, community scientists, clinician scientists that are designing trials, is that we're under pressure for designing a short study so that we can get an answer soon. We don't want to do a study that takes 2 years per patient. Because imagine trying to do this study over a 2-year period in enrolling 200 patients. That may have taken 5-6 more years to complete. And so to try to get an answer in a shorter period of time, you're trying to find a steeper decline to show an effect. Does that make sense? I hope so.
I think that was a very, very clear explanation. Thank you.
Thank you. Thank you. I think it's a really important concept that you have to think about in trial design. And then a lot of other patients have asked me, well, why are you only enrolling patients that have had symptoms for 2 years? And this is also something so important to understand. Again, I want to really extend that we're all on the same team here. We all want a positive study. The scientists, the company, the physicians, of course, the patients and the families. And an analogy I'm going to use is an infection. So let's say you get a cut and an infection in the hand, and it swells up, and you go to your physician and they say, oh my gosh, your hand is affected, but no worries, it's just in your hand, just like ALS can start in the hand. And we're going to give you 7 days of antibiotics, and it's going to work. It'll be done. 7 days later, you're treated, the infection is gone. However, if you let the infection linger, and the infection now has spread throughout the body, affecting arms, legs, your blood, your brain, because it's just spread throughout the body, you let it go for 3 weeks. A 7-day course, a short course of antibiotics is not going to work. And so it's not that that antibiotic is not working. It's just that that same antibiotic is going to take a much, much longer time if we want to see the treatment effect. And so that's the concept of why we try to pick patients that have disease of less than 2 years, because we're hoping these are milder patients where we see the signal faster, we get an answer faster, and the trial at the end of the day is successful.
So then that perfectly leads to our next question of, do you think now that we're coming very close to this important date, that next trials may be either longer or in that slow progressing population if we see successful results?
So you're talking about for this trial specifically, like what's the next trial?
What would be your thoughts on the next step? So if
Oh.
we see positive results in November, do you think that longer trials may be created? I know we just discussed the need for trial design to be short, but
yeah, no, I think that's a great question. I mean, the point of doing a phase 3 study is that it's already looking at a little bit longer time point, and it's also looking at multiple doses. So one, we're hopefully going to get an answer in, are multiple doses needed from this trial? So in comparison to the phase 2 study where just one injection was done, do we really need to repeat these injections every 2 months? Or after the third injection, does the treatment sustain, or does it eventually wear off? And we're going to get some data points on that. We're also, they're planning on submitting this data to the FDA if it's positive. So when you submit the data to the FDA, you're really asking the FDA, hey, is this acceptable enough to try to approve the therapy for all ALS patients? And that's really going to be up to the FDA to give us that answer. So hopefully this is it. There won't be another trial. The last point I'll make is that this trial was such a large trial, the largest trial done in stem cell therapies in ALS. And there was, as the patients know who were enrolled in this study, there was so much blood, urine, and spinal fluid collected. So even if this trial is negative, in my opinion, hopefully it's not negative, but if it's negative, in my opinion, we're going to learn so much from this trial thanks to the scientists at Brainstorm, because they're analyzing it for all different kinds of biomarkers, potentially that can lead to the next drug. So a failed trial in my mind is never negative. We learn a lot from trials, and we learn about what next should be done. But to answer your question, Sarah, I think it's important to recognize that if the trial is positive, Brainstorm's planning on applying to the FDA to say, hey, can we approve this drug, sorry.
So exciting. And I think that kind of, for all the people in the chat that are asking kind of that same progression about slow progressors, it really answers that if we get that FDA, approval, that then they can be included in the next steps for Neuron as well. So
yeah, I mean, we don't know what the FDA will say. Like I said, I've been blinded to all the data. I was just truly evaluating all the patients and trying to figure out, are they doing well or are they not? But we'll find out in that month what's happening. And just important next steps. Yes.
Absolutely.
Just to kind of clarify for those who might have tuned in a little later on in the presentation, how often with Neurone treatment-wise does one have to take it in order to stay on track with the slowing of the progression?
So what they learned from the phase 2 study is that the effects seem to taper off, although they still were much better than the placebo group. If you remember that bar graph I showed at 2 weeks, 4 weeks, 12 weeks, 16, 24 weeks, we saw effects, but they seemed to taper off. So in the phase 3 study, they did treatment injections every 2 months. Because they wanted to try to see, before it completely tapered out of the system, can they achieve one, a more sustained response, or does it even amplify? And that we'll learn from the phase 3 study that yes, they may taper, but then they get injected again 2 months later, and then the treatment effect may be higher. We're going to learn that in the phase 3 study. We don't know yet. And one thing that I've been asked several times is, do you think the FDA is going to approve this for the patients that had the same inclusion criteria as the trial, or is it going to be approved for the slow progressors and the rapid progressors? The short answer is I don't know. We don't know what the FDA will do and how, and I think a lot of it's going to depend on the data. But I will tell you that some of you guys may be familiar with the childhood version of motor neuron disease called spinal muscular atrophy. And that disease, yes, it can occur in children, but there are adult forms of spinal muscular atrophy. And there was a drug that was approved by the FDA for spinal muscular atrophy. That was nusinersen. And the clinical trials were done in children up to teenagers. But when the FDA approved the drug, they actually approved it for everyone. They did not say, okay, no, because we only did the trials in children and teenagers, it's only going to be approved for them. And we have to see what the effects of adults, what the drug effect on adults would be. No, they approved it for everyone. And I think that's a very interesting point to understand because that sort of sets the bar of what the FDA may do for ALS.
I think that also kind of speaks to how Radicava and all the other two drugs came to be. So the process is the same. For all of our international pals and friends on the call tonight, I know the first phase 1 was in Israel. Do you think that this will be expanded to beyond the United States if we see positive results?
I know the mission from Brainstorm is to try to get this for every patient out there. But every country has different approval mechanisms and different filing. And so the US a lot of times sets a precedent for how data will be accepted, but every country has a different mechanism. I know that Brainstorm is fully committed in trying to get this therapy if it's positive to any ALS patient out there. And they're certainly invested in this.
For those of us joining tonight who may not be as well versed in the process of trials, could you maybe explain why it's important that the trials need placebos and how that specifically relates to the lack of biomarkers in ALS?
Yeah, that's a big contender for a lot of patients, and I understand. I mean, at the end of the day, ALS patients, it's a cruel disease. We all are here because we all understand that and we recognize that. And honestly, I've made it a mission to fight for my ALS patients night and day because I recognize that. And in our perfect world, we would be doing trials for any and every ALS patient out there. But what's important to understand is while ALS is considered a terminal disease, and yes, the course is grave, you can do harm in ALS. And we actually learned this the hard way in some clinical trials. So a perfect example of this is approximately 2005 or so, a drug called minocycline. Some of you may be familiar with minocycline. It's actually an antibiotic that's FDA approved and used in the treatment of acne. Well, there was a lot of enthusiasm generated in some early phase data that minocycline is effective in slowing down disease progression. And so a lot of patients were like, hey, this is a medication that's already on the market. I'm going to go to my primary care doctor if you neurologists aren't going to prescribe it. And I'm just going to get minocycline. Why should I wait for a clinical trial? or why should I enroll in a clinical trial? And so some patients were doing that, and other patients were like, no, I see the point of a clinical trial because if any of you have done a clinical trial, one thing to know and understand is all clinical research in the US is free. So if you're enrolled in a clinical trial to get the drug, there's no cost to the patient because we understand you're making yourself vulnerable to potential unrecognized side effects. And so some patients said, yes, I'll do the minocycline clinical trial. And they enrolled in the clinical trial. Some patients got placebo and some patients got drug. And what they noticed in this clinical trial, it was a large study done, that patients that were on minocycline actually did worse. Their rate of progression increased in comparison to the placebo group. And thank goodness for the placebo group, because the FDA, or the Data Safety Monitoring Board, looked at this data and said, whoa, wait a second. Patients on drug are actually doing worse, not better. And they stopped the clinical trial. And they were able to recognize this sooner than causing harm to hundreds and hundreds of patients because of the placebo group. The placebo group in ALS is so important for that reason, is number one. Number two, it's also important because we all know that ALS is so different from one patient to another. And so they try to enroll patients with a very similar disease. Every drug trial has very minor differences, but sometimes those minor differences can be a difference in the rate of progression, even if it's supplements used. A lot of patients these days are on B12 injections. And so even in this phase 3 study, they specifically excluded several supplements, several things that were in clinical trial and other studies, because they wanted to get a very clear answer in comparison to placebo of is Neurone specifically effective, and not confound the data with other supplements, other things that a lot of us believe may help ALS. I hope that was clear. And I know an aggravating point for many patients. I agree. In the perfect world, we would love drug therapy for everyone and have one small placebo group to compare. A lot of this is based on statistics and trying to figure out how many patients you would need in both groups to get a positive result. And that's where, thank goodness, they have statisticians and I don't have to crunch those numbers.
Oh, aren't we all lucky? Not that person. Just because this came up in your topic in the chat, could they just want to have you repeat what you said about the B12 injection? There was a question that came up as to, I guess they missed the comments. So if you could just make that one more time.
Oh yeah, so high dose B12 injections are excluded in some clinical trials because it's actually been in clinical trial. Some of our Japanese colleagues are actually doing some trials with high dose B12 injections. They do have some data suggesting that high dose B12 injections may be effective in slowing down disease progression. So I know specifically for the phase 3 study, they didn't want to confound the data. Some trials allow things and other trials don't. But I thought they did a very nice job they excluded Radicava because Radicava had just been approved in 2017 and the trial had just started. So some patients were trying to get access, other patients were not. And they thought, instead of making the data confusing, you don't know if there's going to be a drug-drug interaction. Let's just get very clean data. Let's get an answer once for all of our patients and be able to sort of move that path forward.
Wonderful. Well, I want to thank you, Dr. Goyal. This has been a very informative a useful talk, and I know there will be a lot of people who will follow it and watch it again just to be able to really absorb all the information, and even more people really, as I know you are too, looking forward to this data coming out in a couple of weeks. We're anxiously waiting and hoping that it leads to positive results and a positive application by the FDA. So on that, we are going to go to our open forum session where we can discuss. You're more than welcome to join us. We unmute everybody and give everyone a chance to speak. But again, thank you so much for doing us the honor to come on tonight and talk. It's been a wonderful hour and a half, and we are so appreciative.
Thank you, guys. I really want to thank all of you guys at Everything ALS, and of course, all the patients for inviting me, giving the opportunity to understand. I know some of the graphs and the data, and if you read the published results about phase 2, it can be confusing, but I hope I tried to explain it in a very straightforward manner, because that's what we're really looking for phase 3. I think this was a beautifully conducted study. I'm so grateful to all the heroes. The patients are really the heroes in the study that dedicated themselves selflessly to do the study. And I really hope and pray that I'm back with you guys, hopefully in a month, and we will hear about these results. So all my love and prayers to all of you. Thank you.